Great. Thank you so much for the kind introduction and for those that are here today. I know it's right before Thanksgiving, and so I appreciate you taking time to be here. Before going into the main part of the presentation, I wanted to give a little background for why I chose the paper I chose. So back a few months ago, we had a presentation from a family who talked about medical errors, and unfortunately, their child had died because of some medical errors that were made. When they were talking about the scenario and about their experience, they quoted this statistic that medical error is the third leading cause of death in the United States. And that sort of surprised me and shocked me because I hadn't heard this statistic before, and that's concerning, right? If physicians, nurses, nurse practitioners, pharmacists, people in the medical profession are indeed leading to a premature cause of death of individuals who are seeking their care. And so this is the paper that came up with that statistic, and that's what we're going to be discussing today. And so as soon as it was published, May 3rd, 2016, articles like this started showing up. It's the second study to suggest medical errors leading cause of death in the US. Medical errors are the third leading cause of death in the US, according to researchers. That the third leading cause of death in the US, most doctors don't want you to know about. Medical errors now third leading cause of death in the US, study suggests. And then one that makes that stretch from this is what researchers are suggesting to this is what is true. Medical errors are the third leading cause of death in the United States. And what is really interesting about this paper is you could Google it, like sort of medical error, third leading cause of death, like right now, and you would find these types of statements that are made that are based off of this paper. The third leading cause of medical death in the US. This was a sensationalized idea that was taken by, or sort of sensationalized by mainstream media. And so this is just an important background to be aware of, is that this is what the public interprets, this is what they read, and not everyone has the luxury nor the opportunity to go and read the initial source. And so that's sort of just something to be aware of as we're talking about the paper today. In terms of background relating to the leading causes of death in the United States, traditionally it has been diseases related to age, cancers. You do have accidents which are involved. Those are one of the leading causes of death, specifically in children. The figure on the right here, it's from the CDC, specifically their National Vital Statistics Report. And what this is showing is sort of the trend since the 1960s to 2019. It didn't include COVID-19, and so obviously we'd see some shifts there with the recent pandemic. I'm sort of seeing an influx in infectious disease, but by and large, most of these are chronic diseases that have caused death in the US population. Now, if we focus in and look on inpatient hospital deaths, which is what the paper of discussion today focused on, we see a decrease in trend from 2000 to 2010. And this was by again, from the CDC, the NCHS data report that was published in 2013. And so some of the numbers have likely changed since then, but this is just what has been published up to date. And so you see, we go from 1,776,000 to 715,000 deaths. So a decrease over time, which is encouraging and what we want to see. When we look at it by age, we see that the majority of individuals who die inpatient are the elderly population, specifically those that are 75 years or older. And when you look at that change from 2000 through 2010, the main increases we're seeing are in those that are 85 years and older, which would make sense as you have an increasing aging with the baby boomer population. And so we're going to see individuals that are a little bit older, that are surviving longer because of medical advancement, specifically in the inpatient setting. Now, when we look at inpatient deaths and we focus in on the cause of death, a lot of these are related to respiratory failure, kidney disease, cancers, strokes, your chronic diseases that come with a whole multitude of comorbidities. When you look at the change sort of in that negative trend that we saw earlier, the only one that's increased over time is septicemia, so getting septic in a hospital setting. All of the other ones have shown to decrease. And sort of these are the percent changes. And again, if you wanted to look into this data on your own, it's published by the CDC, by the HS data brief. And that brings us to sort of that gives us our context for the paper that we're going to be talking about today. Medical error, the third leading cause of death in the United States, published by Marquet and Daniel. This was in 2016. So what are the methods that they used to design this study? If you went and saw the BMJ article, it says analysis on the top right-hand corner. And naturally, you'd think, oh, so they gathered some data, they did an analysis on that data, and then they're disseminating that information. Well, that is partially true. When you go to the BMJ website and you look up sort of the types of papers that they publish, analysis falls more appropriately under an opinion piece. This is the definition that they provide, which is sort of the framework for individuals seeking to publish under this subcategory in BMJ. So they can address topics related to clinical science, ethical policy issues that are important to doctors, policymakers, etc. And they have to present a clearly reasoned argument backed by an even-handed look at the evidence and have a clear message. And so that's sort of the only requirements. Now, the actual papers that were used in this study, there were 4 of them. The data was conducted between 2000 and 2008, and I'll show you the main figure that they had. It sort of breaks those studies down in a second. What's important to know is 2 of those were peer-reviewed, and 2 of them were sort of conducted by the government, sort of like Health and Human Services or Medicaid services. And so they didn't undergo the same process. And they're very different types of studies with different purposes. And so that's something to keep in mind when we're looking at some of that data. And then for their methodology for coming up with the 250,000 deaths per year for medical error, that was they extrapolated data from these papers to the United States population. It's not clear exactly how they did that. It wasn't parsed out super well in the paper, but my best guess and what some other researchers who have made editorials and comments regarding this paper, it seems like they just sort of took those numbers and then sort of expanded them to the US population, so multiplied them by like 350 million. Another thing that's really important to keep in consideration is the definitions used. Definitions are important. They allow us to measure things, they allow us to understand what is going on in a conversation. And for this paper, how they defined medical error is really important. So they defined it as an unintentional act or one that does not achieve its intended outcome. So that's something that I think is really important for us to focus on that we're going to talk about later. And this could include failure of a planned action to be completed as intended, the use of a wrong plan to achieve an aim, or a deviation from the process of care that may or may not have caused harm to the patient. And so this is the definition used that they put sort of in like the first or second paragraph of their paper. Now, when we look at the results, as I talked about earlier, a lot of them had used sort of like Medicare patients that we see to the left of the box. In the main health grades paper, this was sort of a large cross-sectional study conducted by the US government just to sort of understand from a very high level what are some of the risks and some of the projections to understand death trends in the US related to hospital care. They did not do any chart reviews for that study. The other 3, the one by the Inspector General, Klassen et al., and Landrigan et al., those were all done, and they used, they did chart reviews. They looked at the charts and actually evaluated, was this a medical cause of death? Was that preventable? And when you look at that, the only ones that were actually, you were able to definitively say, yes, this was, this individual died, it was a preventable death, it was medical error. There was about, 35, 36 individuals. And then on the right, the farthest sort of legend that says extrapolation to the US data, this is sort of where they get their numbers from. So that this is how many people had would have been impacted with the US data. And so when you look at sort of in their figures at the bottom of the paper, they include medical error as a 3rd leading cause of death in the United States, adjacent to heart disease and cancer, based on their extrapolation report. And what I think is very interesting is that they compare this to motor vehicle accidents, firearms, suicide, which to a layperson might suggest going and getting medical treatment may be more dangerous than, driving my car or, owning a firearm. And so this is just sort of painting the picture for what the paper was discussing. So what do they say in their discussion on, how do we make changes to this? The first thing they suggest is implementing a system within death certificates to notate medical error. One of the qualms they have with how we notate medical errors, you can do that with ICD codes. Sort of in the first slide, we had the ICD-10, which is notating sort of different medical diagnoses and errors that can relate to that. And so you could say that someone had some sort of hematological issue and had a thromboembolus, or you could say that they received too much medication and overdosed. But they're arguing that there isn't a place to clearly notate that this was a result or a direct consequence of medical error. So that's one change that they would say would be important to make. The second that they suggest is doing individual hospital investigations with and have a root cause analysis and sort of a board to determine the cause of death and the prevention. And so this would be both, the second one would be very labor intensive, but essentially you'd have physicians that are tasked with saying, investigating every hospital death and then sort of determining, was this preventable, was it not preventable, what can we do to change this going forward? And so what is our verdict thus far? Is this a good study? Is this a bad study? Dr. Arnst likes to say, are they sick or not sick? And so does anyone have any would they like to share what they think thus far on sort of the paper, or if they had anything to share, or if they got the chance to look at it beforehand, on whether they think, they say thumbs up, this is good, thumbs down, maybe we have some questions about this. I think for me, I'm not very satisfied with how the paper was conducted. I'm not very satisfied with the evidence relayed, nor how it was left leeway for the media and the public to sort of go leagues and strides with the information. According to Ganali and Dunn, they're one of the papers that were included today to sort of help with the critique. They had 4 qualms. One was the improper definition. 2 was the data inconsistency and tabulation of the medical errors that was done. That there was extrapolation error and that there was misinformation regarding the death certificates. So first, let's return back to the definition we talked about earlier, that a medical error is defined as an unintended act or one that does not achieve its intended outcome. What this begs to question is that are good faith, evidence-based medical interventions that do not achieve their intended goal medical error? Let's suggest that an individual is diagnosed with a malignant carcinoma that has a 100% mortality rate if not treated, if not undergone surgery. But if they do have surgery, there's a 30% chance that they could die on the table. If they die on the table, that would be classified under this definition as a medical error, even though the risks were articulated to the patient. It is a good faith, evidence-based intervention, but the intended goal, patient, living and not having cancer, was not achieved. Therefore, it is considered a medical error. Second, I think it's important to talk about the data inconsistency and tabulation. There was no conversation about the quality of the data that was conducted. One means that they could have done so was sort of grading the criteria, using the grade criteria format, and saying, is this study high evidence, moderate evidence, low evidence, to suggest that this trend is true? They didn't have that conversation at all, which is concerning. Because the studies, they were heterogeneous. They were designed for different purposes. We had the government wants to just inform policymakers of trends that could be true. There was one that was more of a cross-sectional study, 3 that were doing chart reviews. And so the methodologies and the definitions, even within the studies that they chose, were very different and hard to sort of collate into one paper that can make a single argument. Second, they used the I category for the NCCREMP index, and that's sort of how medical examiners can categorize the death that someone has undergone. And I essentially says, if you look at the definition, that it may have contributed to death. So medical error may have contributed to these deaths, which lends to the question of why were there not point estimates in their data analysis, and why were there no confidence intervals provided? There's no way to really understand, was this data statistically significant? Is it not? Is it reliable? All we have are these crude numbers to look at, which to a layperson, they wouldn't ask those questions of, oh, well, there isn't a confidence interval. Why should we listen to this study? Why should we, take this as truth if we don't know what the margin of error is here? So that is another critique that I have, and that some other individuals that have read some of the read this paper and made editorials and things about it have had. There also there's some serious issues with the extrapolation of their data. First and foremost, as you can see in this right box, two of the studies only focus on Medicare patients. And the criteria by which to qualify for Medicare is you're over 65 years old, you have a permanent disability, and or you have end-stage organ failure. These are our sickest patients that come into the hospital, and that's half of the individuals or half of the studies that they included in their paper. These are also the two that were not peer-reviewed. Klassen et al. and Landrigan et al. Were peer-reviewed studies. And so that's something to keep in consideration as well. Second, I think it's interesting to look at the geographic representation of the studies. The Landrigan et al. Had 10 hospitals in North Carolina. Now, it would be absurd for me to say that if I'm looking at, food preferences for individuals in North Carolina, that is representative of the entire United States. Is it not also a little absurd to suggest that the medical treatment provided at these 10 hospitals and the medical errors that were conducted between 2002 and 2007 in North Carolina are also extrapolatable to the entire US population? And so this calls into question, is this data true? Is this really something that we can make these large, broad claims about? It's also important to consider, we talked about that the age for a lot of these patients is over 65, being part of Medicare, but also they didn't include anyone under 18 in any of these studies. That's partially because of IRB processes, I imagine, for the ones that had undergone peer review. It's more difficult, perhaps, to look at individuals under 16 years of age, but that wasn't talked about in their limitations. And so that is something to consider as well. Now we're looking at the suggestions that they made. We need to make edits to the birth certificates. Some of that work had actually already been done by Howard et al., Hogan et al., and Hogan et al. In 2012 and 2015. And what they had done is they had said, okay, let's assign investigators to assess the quality of care problems in individuals that may have undergone death in the hospital. And what they found is that 3 to 5% of these deaths were likely preventable. And they defined likely preventable as if you had received optimal medical care, you would have a greater than 50% chance of survival. And so if you apply the same extrapolation methodology to those studies, as was done to the one that we're discussing today, you would only yield about 25,000 deaths, not 251,000. And it is important to know that those are 25,000 deaths that potentially could be preventable. And that is something that we should do work towards to, develop methodologies and protocols in order to reduce that. But looking at birth certificates may not be the most effective way to do so. What another study had suggested is actually looking at autopsies, is increasing the amount of autopsies that are done. Back in the 70s, I believe, it was required by the federal government to have about 25% of individuals who had died within the hospital to undergo autopsy, and then assessed by pathologists to determine cause of death. Now, because of costs, because of family preferences, it's more so in the single digits. And so what that author had suggested is, if we increase autopsies, we might be able to actually understand, what is the cause of death? Was it from some sort of comorbidity? Was it from, a physiologic reason? Or is there something that we as physicians, as pharmacists, as researchers, as et cetera, would be able to do to prevent the cause of death? And then that's something that you can objectively bring to M&M rounds to then discuss with and sort of improve the hospital processes. And then that's something that you could publish data about to disseminate and provide maybe political policy that could be passed through legislation to improve patient care outcomes. And so what are some takeaways and some comments that we have regarding this study? The first one that I think is important to talk about is the concept that sensationalism can be very dangerous. We saw this recently with COVID-19 when individuals were seeking various medications such as chloroquine for their COVID infection. When there was further research done, it was found that that isn't something that actually reduces mortality. It actually increases mortality when you had a larger randomized multi-site study done. But the public, they still latched onto that initial sensationalist idea. We saw this too with vaccine hesitancy after researchers in the UK suggested that this was related to autism. And so then you see this epidemic of individuals refusing to get vaccinated because they're afraid of potentially giving their child some sort of adverse outcome that wouldn't have happened otherwise. And so what I think is really important is we need to be aware that as medical professionals, as scientific professionals, that how we articulate our ideas and research, it can cause damage. And so we need to be very careful. I think it's also important to talk about the risks for overtreatment. There have been a multitude of studies that have been done that talk about malpractice and how physicians, this one specifically surveyed over 2,000 physicians via survey, part of the AMA, and asked, why do you treat patients for certain things? And why do you overtreat patients? And the vast majority said fear of malpractice. They're afraid of being sued. They're afraid of not catching that disease, right? And partially maybe to protect themselves, right? It wasn't that there were borderline indications for the tests or that they weren't sure if the test had been done beforehand. They were afraid of being brought to court. And papers like the one that we're talking today could potentially increase the risk for individuals undergoing malpractice suits. And so it's important to talk about that and think about that. It's also important to consider that the paper only talked about mortality. There was no discussion on how medical treatment could increase the morbidity that patients experience. And that would actually be something that I think would be very interesting is, what proportion of individuals that undergo some sort of medical intervention that their quality of life decreases or increases? How does the medical care that we provide for X, Y, Z impact morbidity as well as mortality? So that is something that would have been really important to at least have a few sentences to talk about in their papers, that we don't only want to focus on life versus death. There is more to the role of a physician than preserving life. You want to improve life and the quality therein as well. And finally, I think, as we talked on a little bit earlier, is that we want to be just judicious in our evaluation of the literature. And so if you see some sort of headline, in the Atlantic or New York Post, Wall Street Journal, New York Post, go to the original article, read it for yourself and make a decision and say, this is actually a really good study. They did X, Y, and Z. It was a meta-analysis or it was a randomized controls trial, and this is well done. Or is it a paper that may have had some qualms, that could be improved, and the headlines were sort of being more sensationalist about it or weren't sure how to interpret that data. And so I think it's as researchers, as physicians, as student doctors, we almost have a responsibility to be judicious of the evaluation, but also how we conduct our research, so that we're not giving that slack, that leeway for what we're trying to articulate to be misconstrued. And so this is the bibliography of the papers that I talked about. The main one was this Macari and Daniel. The Shojani was a rapid response that was published, I want to say 10 or 13 days immediately after the Macari one, that talked about some of the potential damages and concerns with the paper. And then Giannoli has written a few different articles and went into more depth about the history of some of the papers that were cited and sort of a more thorough critique than just a rapid review. All right. Any questions, comments, concerns? That's all that I had prepared for today.
As the host, I reserve the right to make the first comments.
Fair
That
enough.
would be, first of all, thank you so much for your presentation. It's clear you did a lot of homework. For those of you who don't know, I offer a coaching session a day or a week or so prior to all of these presentations, and coachability is very high in this one. Student Dr. Williams, your coachability is excellent, and I appreciate that about you. Housekeeping items in the chat. I've just dropped a draft schedule, and it changes for the remainder through even the summer. And I'll drop one more thing in the chat and make my comment here. This is the next talk, and if you want to peruse who's coming next, just click on that first link. This is a highlight of who's coming next. So back to student Dr. Williams. First of all, as a PhD scientist, it's clear to me you're a trained skeptic, and that's what you should be as a practicing clinician, physician, scientist. So I appreciate your approach to this paper and pointing out the need to be a trained skeptic with this kind of sensationalized media. Oftentimes, this does happen. I myself experienced it. I published a paper that a certain compound can induce P450 and might not be good if you're also undergoing cancer treatment. So it was a herb-drug interaction piece. And it got picked up by API and some other news wires. And the next thing you know, I'm getting phone calls from, the Journal of Exercise Physiology, and they're printing all this stuff about because the drug was popular with weightlifters. So if you're lifting weights and you have cancer, you better stop taking this supplement because it's going to kill you. And it just spread like wildfire, and it was completely sensationalized. So from a personal point, I appreciate your presentation very well. I really liked it a lot, and you did a great job. A very, very, very good job. So I'll open up the floor now to any other comments.
Just to make a comment off of what you said, Dr. Staudinger, I think it is important that I'm not saying that the researchers are responsible for the media sensationalizing their ideas. And there another paper that I had quoted said that as well, is that they're not responsible for the media taking these claims and sort of extrapolating and expanding upon them, but they are responsible for maybe not including some of the limitations that would have been helpful in preventing some of that. And so I think for the purpose of this paper, if they'd included some more limitations on the study and sort of saying that, this is something that could possibly be true, but there are all these other things that make it less likely. If they had confidence intervals, for instance, that would have been helpful in sort of modulating the degree at which news outlets could run with the sensationalist ideas.
It won't be the first time, and it definitely will not be the last time that such a thing happens. I guarantee.
Unfortunately, yeah.
Dr. Wolf, you typically have a question. You must have something. I see you're logged in twice because you liked it so much.
No, I've got web problems. I keep falling off. But Dr. Schmidtke had her hand up first, so okay. Why didn't you give somebody else a chance? Because I always hog it.
Okay, go ahead, Dr. Schmidtke.
Yeah, thank you. Student Dr. Williams, that was excellent. Thank you very much for putting together a really insightful talk today. I'll be honest, one of the reasons I came, of course, was because Dr. Staudinger invited me, but the other was because I've come up against that particular researcher before, Dr. McCarty. And while I appreciate that you were trying to give the study an isolated look, I can say, unfortunately, that this is a history with this particular person. He's part of a kind of a community of folks that sensationalize data a lot. So that's unfortunate. And so my question for you is, he is one of several people that have sort of an outsized role with the media. And so what do you think is our responsibility or your responsibility as a future physician for sort of reclaiming that microphone, or for how do we make sure that good information is being shared with the media?
Yeah, I mean, I think it would be a lot of the critiques that were made about this were made within the scientific sphere, right? So, a rapid review, or, let's publish a scientific article that combats this. I think that is one way to do that. I think another way to sort of address that is maybe to go to the media, write an opinion piece that gets published by The Atlantic, where you say, hey, this was something that was talked about. This is why there are some issues with what's going on. Something that is more digestible and accessible to sort of the widespread like layman population. Most people aren't going to be going and searching, in academic medical journals when they see something like this, but they might read an article that comes up on NPR or comes up on, New York Times on their phone. So I'd say that is one way to combat it. I think journals could be more judicious in redacting some articles. This one is still out there. It's price walled, and so it's hard to get to if you don't have some sort of means of doing so. But if there have been a lot of qualms and questions on to whether the article has done damage, that's one thing that journals could do. But I think they could be more judicious. It was pretty evident that this was not an even-handed evaluation of the literature, which was one of the requirements for the analysis pieces by BMJ. And so part of it, I think, is on them in being more careful about what studies they approve and sort of the review process that they give credence to. He also had I think, published a book. It was in his sort of at the end of the paper. It was like a paragraph about potential things that influenced his position, and he did say that he had published a book on sort of healthcare influences, or I could find that if you want. But yeah, that'd sort of be my 2 cents on it.
Dr. Schmidtke, can you elaborate on your interface with this particular author a little bit for us?
Yeah, so during the COVID pandemic, I was a science communicator. And so I was one of those folks that was talking to the press to really kind of correct a lot of the misinformation that was being spread. And so I wanted to let you know that there are societies that you can be a part of. I think AMA has one, and I don't know, it's possible that ACOM or something like it has it too, where you can be part of a list of sort of vetted experts that the press can refer to. Like if they have a question on diabetes, they know who to go to, or COVID-19, then they know who to go to. And so he was a big part of my operation, was trying to combat the things that he was saying. He was a little bit of a COVID denier in terms of the impact, especially with long COVID. So that was my experience. I will say that not all media folks are bad. A lot of them really are trying to do good work, but they don't have the level of expertise that you have, student Dr. Williams, of course. And so I think there's a responsibility to make sure that you're educating them in addition to just sharing your talking points. But I would caution you is they will never send you what they plan to write before it publishes. So you have to just be very careful about what you say, understanding that any part of it can be taken out of context. And so that would be just my advice to anybody on the call.
That's good to know. Thank you so much.
Student Dr. DeYoung, go ahead.
First off, I wanted to say very good presentation, much like they have been saying in sequence here. I also wanted to note that the inclusion criteria for the medical error kind of blew me away, just for that it was like a intervention that does not achieve its intended outcome. I feel like that is much looser than what would be represented by just the 2 words medical error to the rest of the layman public there. And I think that was a really good job pointing that out, because to me, that says, let's say someone gets an allergic reaction, some sort of hypersensitivity to a good faith intervention that was done and expires from it, then that would fall into your medical error grouping, even though it's not truly a medical error. Because when people read those 2 words, they would assume, this is something perhaps negligent that was done. For example, like the Redonda trial in Tennessee, for a good example there, where you have medications that were bypassed or passed some sort of fail-safe and caused a patient's demise. I think those 2 separations there are really key, and I'm glad you highlighted that, because even to someone like me at this point, I didn't really understand the full scope of what went into that timeline of it becoming a stated fact in the, I guess, the open media, where that's just a assumed thing that medical errors are a third of, you know, in hospital deaths. I also thought that the inclusion of Medicare especially slants things, because it takes away from things that could be potentially tragic true errors, such as the guest speaker from our bioethics lecture there, where you have a young female who expires in the hospital from something very obviously preventable, but those aren't even included in the tabulations that we're discussing today. So it's kind of all over the map, and I'm really glad that you've kind of highlighted some of those key pieces.
Yeah, thank you, Ben. If you're interested, a lot of the arguments and stuff that were presented were talked about either in one of the other two papers. And so I sort of added on some of my 2 cents, but a lot of it was previously in the literature. But yeah, I think, we need to be, they could have at least mentioned that their population was older and that would inflate the numbers. But in their paper, they actually said that because they didn't include outpatient individuals, that the number that they suggested would be inflated, which would suggest that greater than 1 in 10 patients who has an inpatient stay sort of expires as a result of medical error, which is that is crazy. So yeah, thanks so much for your comment and yeah.
For those who are interested, all of the articles are posted on the Canvas page in the link that I provided earlier. Dr. Gordon, I see you're unmuted. Did you have a question?
I was not unmuted, but I do want to congratulate a student doctor for a fantastic presentation and what you looked into. And I also wanted to echo Dr. Schmidtke's comment. Unfortunately, there are some researchers who sensationalize intentionally, and that's unfortunate, but that is something that happens for whatever gain, that whatever their reasons are, but it does happen.
In the PhD biomedical science field, it's kind of publish or perish, get a grant or die kind of thing. That kind of pressure puts a lot of folks who are kind of walking the edge of being honest with themselves and their data, kind of tends to put folks on the proverbial garden path. And as a credible expert in a very niche field in my career trajectory, I can tell you with 1000% certainty, there is a lot of BS in the literature. I've seen it go by, and I call it out whenever and wherever I can. And so the peer review process has something to do with it as well. Oftentimes articles will end up on a first-year graduate student's desk, and they're just simply not qualified to review. Alternatively, I'll relay this experience to you guys. I was reading and reviewing this research article, biomedical research article for a really reputable journal. And I'm reading the abstract and the introduction, and Bell's spidey sense is starting to tingle. I'm like, darn, that's really good writing. I kind of recognize it. And then I realized I wrote it. They just cut and paste it. And so, I called up the editor and said, this paper can never see the light of day because blah, blah, blah. So just thank you for your presentation. And I concur. There's a lot of over sensationalized stuff. My PhD mentor told me, or I extrapolated from his behavior, and he's a big fish. It's okay to stretch your data as long as you're right. Overinterpretation is, it's a sin unless you're right. And more often than not, he was right. And as long as you don't cross the line, I think there is a temptation to try to interpret your data in the best light possible, but beware the garden path. especially from clinicians and physician scientists and PhDs. Highly educated folks tend to fall in love with their own hypothesis and reject everything else that goes against it. So it's a cautionary tale. Dr. Wolf.
Dr. Wolf does have something to say.
Well, hopefully my internet won't kick out here immediately. Are you still hearing me?
Yes.
All right, awesome. So I was intrigued by the notion of ICD-10 code for medication errors. I'm going, boy, lawyers would sure love that if people were acknowledging their errors. And we are also in a society where peers don't necessarily want to know the outcomes of other peers and outcomes research and like stuff like that. Nobody necessarily wants to be the worst physician from an outcomes perspective in a practice. So it seems to me that there are problems at that level. And then there's also the problem of just messed up diagnoses. I mean, there and so when people have misdiagnoses or the system 1 versus system 2 type thinking where they're so convinced that something is right, kind of like what Dr. Staudinger was saying, that they feel or they fail to go back and question their assumptions appropriately and things like that. Those are all parts of medical errors that probably never really get well quantified. And so it seems to me that there's ample opportunity for errors increasing that fraction as well.
Right. And I imagine that a lot of those would likely be affecting more morbidity. I think mortality would sort of be like the accumulation of a lot of small mistakes over time. And I think, yeah, I mean, I think that would be something that'd be really interesting for folks to look at is, how often do like misdiagnoses occur and how long does it take for those to get caught when they do occur? Because I'm sure that they do, that you think it's one disease and it ends up being another, or that a wrong medication was given for whatever reason because they missed some sort of interaction with another med. And so I think, maybe if there's some sort of policy to have a second set of eyes look over something, now that we have telehealth capabilities, that would be more feasible, or something of that sort. But yeah, Dr. Wolf, I think you're definitely on the right track in that there are medical errors that occur, and that just because this paper didn't do a great job at shedding light on what that looks like, doesn't mean that they're not happening, and that as a system within the medical profession, we shouldn't try to reduce the level of those medical errors that do occur. I think M&M rounds are one way to do that, but there are certainly other means that could catch things before it lends towards someone expiring.
Well, the other thing,
I think you might have cut out Dr. Wolf.
You're muted again at some level. Check your headphones. Well, while he's trying to rectify that situation, I just want to reiterate, thank you so much, student Dr. Williams, for showing up. And one measure of a good presentation is the number of questions that arise after it. So feel proud as
Well, thank you.
I do of you. So
Excellent job.
yeah. We'll give Dennis 10 seconds.
Looks like you might put something in the comments.
I appreciate
Yeah.
that's from student Dr. DeYoung.
Mm-hmm.
He appreciates overall the topic seems too broad with too many niche criteria to quantify with a single third leading cause in the near future. I think it may need some years of building up statistics on each disease that contribute to, and that's where it ends. All right then.
Well said. Student Dr. Williams, I could just add something when you talked about sort of patrolling or looking at medical errors. That's part of a quality improvement, quality assurance plan that should be happening in hospitals, et cetera. And so that is also good field, fertile area for review before you get to an M&M. You hope you don't get to an M&M because that's pretty the drastic outcome, right? So quality improvement and assurance programs within institutions are supposed to help with that. And if we could publicize those a little bit more, that might help. Generally, those kinds of internal researches are done without under the guise of a protocol because they're used for quality improvement. So they may not necessarily be published, but it doesn't mean they couldn't be published. So as you and your other student doctors, colleagues think about projects to do, think about those kinds of projects that can be done, say, for example, with Dr. Arndt's, with some hospital data that would actually be helpful to those in training as well as practicing clinicians for, say the most common medical errors or the most common misdiagnoses or things like that, which typically don't get published because it's more of an exploratory, descriptive type of research, but it's just equally as important.
That's really interesting. Thank you for sharing that. I didn't even know that, quality improvement reports and things were being done that weren't being disseminated for, collaboration of the sort. So thank you so much for sharing that. That's really interesting.
If I may,
Go ahead.
If I may tack on to what she was just commenting there, I know from personal experience, a lot of hospital systems will have their own internal, especially infectious disease, like epidemiology and those kinds of things that are designed to just focus on their system alone. And so there becomes then very little interplay between systems to create this better picture of the overall image of what could be going on with, like, let's say, infection control around central lines or like other catheters and things. And from that standpoint, it becomes a kind of North Carolina discussion like you're leading there, where is this truly representative and why aren't we able to collate some of this a little bit more effectively to come up with a decisive statistic on what things are, let's say, contributing to septicemia, what things are contributing to maybe overdosing, and again, on a patient by patient basis. But I think that's a communication would be the next kind of phase of that.
I agree with that. And I will also just comment, as our healthcare systems are coalescing and enlarging. So if you could imagine the power of if Mercy Health System in its regional infiltration, and if Cox Health System, say, for example, got together and like compared their data, how helpful that could be to each other, right? So they're required to do the QA as part of their, I'll use accreditation, which is not really the quite right word, but as part of their, process for being allowed to operate as a hospital. And part of their health grades, they get health grades assigned to them as well. But if they would pull, like compare data, then maybe we could all help each other. And it would be more representative because it would be more widespread.
I see a comment in the chat from Dr. Talley, and Dr. Talley, I took the liberty of Googling it, and I see that there's a book dedicated to it. And I put that link in the chat for everybody to click on.
Yeah, and that's all about, quality improvement. And it was about infection, hand washing techniques and checklists and observations of the surgeons. And it was very, very effective. Just a simple little checklist on how to wash your hands properly. And so I think this stuff is really important. I'm working on something right now that came out of a paper with some students about the lack of, I want to say, let's see, immigrant populations who speak Spanish in the United States not being involved in the PrEP adherence. And so I decided, this is interesting. So I looked into it in depth, and I found out, number one, that the prison data is a mess. I mean, they do a count of how many people have HIV in the prison systems, and this is across state and federal and local, twice a year. Now, you and I both know that people are discharged sometime after that first 6 months, and then sometime maybe in between that 12. I mean, the data collection is appalling. And in addition to that, looking at, program issues with, the federal government, I'm sure was well intended when they said, we're going to make PrEP free. But the problem is that disseminating it, plus you have to pay a doctor's fee and you have to pay a clinic fee to get it. And these are the things that mess up good intentions, I think. And so I think we have to look further, and we have to look, you're absolutely right about the quality of the research, the quality of the data. It's absolutely essential if we're going to come up with meaningful approaches. I feel that very strongly. I'm done.
Excellent job again. I'm going to sign off now. Appreciate it. Thank you, Dr. Staudinger, for continuing to host these.
Thanks for joining.
Thanks for joining. All right.
Okay, are we done?
Dr. Talley, I think I'm thinking of the same book, the